Hello, my name is Jon Gould. I'm professor and chief of general surgery at the Medical College of Wisconsin, and I'm going to discuss revisional options after failed myotomy. These are my disclosures. Surgical myotomy is associated with good long-term symptom control. This is data from a single center in Italy with 1,000 patients undergoing myotomy over a more than 20-year period. And you can see that with more than 200 patients who had greater than 10-year follow-up, 84% had good symptom control at that 10-year interval. And there was a subset of this cohort that was followed out to 20 years, and these patients had excellent symptom control out to 2 decades as well. Symptoms obviously recur, and of interest is the fact that they typically recur early. And in this Italian study, of those who developed recurrent symptoms, 50% manifest these symptoms within the first year of surgical treatment of their achalasia. Again, from the same Italian study, it's of interest to note that early primary treatment is associated with better long-term outcomes. And so this is looking at the rate of patients to undergo treatment who are symptom-free at various intervals out to 10 years. And as you can see, patients with stage 1, 2, or 3 achalasia as determined radiographically had much better outcomes than those with stage 4. And for a refresher, stage 4 achalasia as assessed radiographically, these are dilated esophagi. They're more than 6 centimeters and they're sigmoid shaped. So this is your end stage achalasia. So when you perform a primary myotomy on people with advanced disease, the long-term symptoms aren't as good as they are in earlier stages. But of interest, this is a glass half full situation. 65% of those people did get good long-term durable relief, even with end stage achalasia following a myotomy. Looking at myotomy and comparing it to different interventions, there's all sorts of data out there. This is data from a randomized controlled trial published in 2016 looking at myotomy versus pneumatic dilation as a primary treatment intervention. And you can see the results are fairly similar out to 10 years, pretty good success rates, about 84% or greater at 5 years as success was defined in this particular trial. And again, similar results for pneumatic dilation, which the results with pneumatic dilation tend to be directly related to how aggressive the person performing a dilation is. And the more aggressive you are, there is some incremental risk that's associated with that. So you'll see lots of different outcome numbers when it comes to pneumatic dilation. For example, here, this is another randomized controlled trial looking at POEM versus pneumatic dilation, again, for primary treatment of achalasia. You can see here that at 2 years, pneumatic dilation had a 54% success rate in this particular trial based on how they define success. And POEM was very successful at about 92% success at 2 years. And so the point of this is that the interventions that we have, be it myotomy, pneumatic dilation, or more recently POEM, are associated with pretty good long-term outcomes, but there is a cohort of patients that fail these treatments. So when myotomy fails, there's a whole bunch of reasons why this might happen, and it's really critical to sort through the differential diagnosis before treating these patients. So the differential diagnosis for a failed myotomy includes obviously an incomplete myotomy at the primary procedure, fundoplication failure, and this can be a lot of things. It can be the fundoplication was not constructed properly. It can be that it slipped or moved. It could be that the hiatus was closed excessively tight relative to the size of the esophagus, things like that. There may be peptic stricture. This is more likely in people who have GERD. And as we know, following myotomy and in achalasia, patients can manifest GERD without having significant symptoms. So this is a risk, especially in patients that don't have some sort of an anti-reflux procedure performed concurrently with their myotomy. Periesophageal scarring can make it difficult for the esophagus to empty and result in persistent or recurrent symptoms. Esophageal cancer is a concern. Functional dysphagia, so this is dysphagia in the absence of outflow obstruction. And then impaired esophageal emptying related to the morphology of the esophagus. And these tend to be your sigmoid-shaped esophagi that don't empty very well, regardless of the presence of the myotomy or not. So sorting through this differential requires the right evaluation. And so evaluation includes tests like time barium esophagram. You can see here on the left is a dilated esophagus that is emptying relatively slowly. Here it is on the right after 5 minutes, and there's still retained barium, as you can see, in the esophagus. We like to do these with a marshmallow challenge, some sort of a bolus, barium soaked bolus, to see if this empties or reproduces symptoms. So a really important part of the diagnosis. Endoscopy, obviously, look at the mucosa, EGJ, rule out pseudoachalasia, and high-resolution manometry is critical. And then if you suspect pseudoachalasia, sometimes a CT or an endoscopic ultrasound can be helpful as well. So I wanted to talk a little bit more about high-resolution manometry. Obviously, this can tell us a lot about the status of the myotomy, the function of the esophagus after a myotomy in a patient that's having symptoms. Sometimes, however, it's difficult to tell in a patient with an esophageal outflow obstruction if that is related to an incomplete myotomy. Is it related to excessively tight hiatal closure, fundoplication that was made improperly that's resulting in an outflow obstruction? And so there are some maneuvers, some provocative maneuvers that can be used during high-resolution manometry to sort this out. And so during the manometry, you can administer either amyl nitrate or CCK or both. And so for CCK, pharmacological administration of CCK is associated with competing excitatory and inhibitory effects on the esophagus. And usually the inhibitory effect is predominant. So in achalasia, when inhibitory innervation is impaired, you see a profound excitatory effect. And so you get this paradoxical hypercontraction in patients with achalasia who have, and you can see if this is an incomplete myotomy, the residual esophageal muscle and the distal extent of the incomplete myotomy will have this sort of hypercontraction, as you can see here, following the administration of CCK. And this is a paradoxical response and pretty obvious in folks with achalasia. You can also administer amyl nitrate. And so amyl nitrate is a medication that produces rapid relaxation of smooth muscle. And when amyl nitrate induced IRP falls significantly lower than deglutative IRP, this demonstrates that endogenous smooth muscle relaxation is impaired. And so you can see here in this high resolution manometry on the far left that this is a normal deglutative IRP before amyl nitrate. And then once amyl nitrate is administered, you can see the pressurization at the LAS just disappears. So this would be consistent with a incomplete myotomy in a patient who's had a myotomy. And you can see the rebound contraction here. This is a commonly observed phenomenon shortly after the amyl nitrate wears off in these patients. So these are provocative maneuvers that can really help sort out whether this is a fixed outflow obstruction from something like the hiatus or a residual lower esophageal sphincter in an incomplete myotomy. So once you've sorted out the cause for the failure in a patient who's had a myotomy for achalasia, the treatment is sort of determined by the cause. So for an incomplete myotomy, there's a number of options, which would include pneumatic dilation, reoperative surgical myotomy, POEM, or esophagectomy. For a peptic stricture, if this is the diagnosis, dilation is the treatment. Proton pump inhibitors obviously is something you need to add. This is a caustic stricture, GERD-related stricture in a patient who's had a myotomy, and so you need to be aggressive about preventing that from recurring. In a patient with functional dysphagia, this is really something that the patient should undergo counseling, dietary modification, reassurance for. The esophagus is going to continue to empty. It'll empty better, they'll feel better if they can perhaps modify their diet to eat things that will get out of the esophagus a little more readily, portion control, chewing their food more thoroughly, maybe washing things down. So you can really help them out just with behavioral modification. And then in end-stage achalasia, same sort of deal. If you can get these patients to modify their behaviors in a way where they're doing well enough without surgery, then that's obviously a good thing, especially in some of the folks who present who are pretty ill, because the treatment for this surgically is esophagectomy, which is obviously a big deal and associated with morbidity. There's some other potential options, whether it's a stapled cardioplasty or a resection of the GEJ that I'll cover in a little bit. So pneumatic dilation for incomplete myotomy. This is something that over the years has been proven to be pretty effective. And most series have shown that you can improve a patient's symptoms about 90% of the time by doing this. You often need to repeat it, however, just like pneumatic dilation in patients who have not had a myotomy before. You can see from the images here on the left, you can sort of faintly see the balloon in the lumen of the esophagus with a waist. And on the right, you've got the balloon fully inflated and the waist has disappeared. So here's the waist right there where my pointer is. I don't know if that shows up on Zoom, but here it's been completely effaced. And this is proven to be really safe in patients who've already had a myotomy. So that's probably first-line treatment for a lot of folks with incomplete myotomy. When that fails, reoperative Heller myotomy is an option. You can extend the previous myotomy, which can be pretty difficult, to be honest. A lot of these folks will have a fundoplication. If they've had a door fundoplication and anterior 180, it can be hard to get into that plane between the myotomy and the fundoplication without tearing the mucosa. The myotomy and the underlying mucosa, the mucosa is not as obvious as you would think to sort of see. You can't see the clear muscle edges. The mucosa turns a little bit leathery. It's a little difficult to work with. So extending it is sort of tough, but it's an option. You can make a new myotomy, which is my preference. And you can either go at the 3 o'clock position, which is the easiest position for extended myotomy onto the stomach, or you can go at the 9 o'clock position as you're looking at the esophagus. This is on the lesser curve. One of the issues with this is that it's a little harder to sort of visualize. The lesser curve vasculature will get in the way of the myotomy as you extend this onto the stomach. Stapled cardioplasty is a salvage operation I'll talk about. And if you're going to consider this or want to save that as an option in the future, to get the new myotomy away from where that staple line would be is a good thing. And so putting the second myotomy at 9 o'clock preserves that option of a stapled cardioplasty. And you can do these transabdominally, laparoscopically, thoracotomy, thoracoscopically. If you're going to go in through the chest, this is somewhat limited by the presence of a previous fundoplication, so keep that in mind. These are really tough cases. You've got to go really slow and be very careful as you take the fundoplication down. And doing these second myotomies is really tough. I've done a fair number of reoperative myotomies in my day, and I am very glad that we are able to offer patients POEM now, especially for these folks who've already had a surgical myotomy, because POEM after Heller I'll talk about, but it's a really nice procedure. So reoperative Heller myotomy, this is one of the largest series I could find, a series of 58 patients who had reoperative surgical myotomy. Intraoperatively, they had a 19% mucosal perforation rate. They had a 5% leak rate. These are both higher than you would see in primary myotomies. And after a median follow-up of 34 months, one of the most interesting things I found from this series is looking at who got durable relief from this. So the patients who had incomplete myotomy had pretty reasonable results. More than 70% of those patients had a resolution of their dysphagia out to the follow-up interval. When patients presented with fibrosis and they underwent reoperative Heller myotomy, they did not do very well. 30-some% of them got relief to the follow-up interval, and most of them did not. Failed fundoplication, these patients did better. Patients with a mucosal stricture, reoperative Heller myotomy did nothing for them. So wouldn't offer this sort of a intervention for people with fibrosis or mucosal stricture. And it makes sense that reoperative myotomy wouldn't make a difference for either of these problems. POEM for failed Heller, I mentioned this. The beauty of this is that you don't have to go in the abdomen. You don't have to take down the fundoplication. You avoid all the scarring associated with the previous operative field. And POEM after Heller is not that much more technically difficult than a primary POEM. And in fact, if a fundoplication is present, that's great because the GERD outcomes are better in these folks. One particular study published in Clinical Gastroenterology and Hepatology was a retrospective comparison of 90 primary and 90 poem after Heller patients. And you can see from a technical success perspective, very high rates of technical success in both cohorts. Clinical success or resolution of dysphagia, 94% in primary poem versus 81% in poem after Heller, and a similar rate of adverse events in both at around 10% plus or minus. And then there's the patient who's already had a poem. So they've had a poem myotomy and they have persistent problems. And so poem for failed poem is an evolving technique. Multi-institutional study of 46 patients was published. Again, great technical success. Clinical success is about in the range of poem after Heller. And the complication rate, as you can see, about 17%. These are mostly bleeding events, which were controlled endoscopically. So again, a promising option. And then there's your end-stage achalasia. So this is radiographic stage 4 achalasia with a dilated sigmoid esophagus, as you can see in this chest x-ray. Symptoms are associated with stasis in the dependent portions of the esophagus. If someone like this comes in, obviously with no prior myotomy, then I would do a minimally invasive myotomy in this patient. If they're a failed myotomy with an x-ray like this, you've got some options. One, I've talked already about sort of dietary and behavioral modification. If you can get this patient through without an esophagectomy or any of these other things, especially if they're higher risk, that's a great thing. Esophagectomy is an option, obviously a pretty morbid thing to do to folks. Resection of GEJ and staple cardioplasty are two other options. You can see on the left what a stapled cardioplasty is. And so this involves a gastrotomy, intraluminal placement of the stapler, stapler across the esophagogastric junction and up along the angle of His and cardia there with a stapled esophagastrotomy right at the GE junction, and then you would close the greater curve gastrotomy. And then resection of the GEJ with Roux-en-Y esophagojejunostomy, as pictured on the right, is another option to esophagectomy. These are novel approaches to end-stage achalasia. There aren't great series published of this, not large series with long-term follow-up, but it can be successful and it can be done, although there is morbidity associated with each of these options. So in conclusion, symptoms can recur after myotomy for achalasia. The cause of the recurrent symptoms really drives treatment, and so the diagnostic evaluation is critical. Dilation, redo myotomy, poem for incomplete myotomy. My preference would be poem. And then complex procedures. These procedures are all complex procedures with high potential for morbidity. So expertise in the multimodal management of achalasia, of primary achalasia, is really important, including poem, Heller, pneumatic dilation, all of those things and those options available to you. These are all important things for people that are going to tackle patients who have recurrent swallowing issues following a Heller myotomy. And so with that, I would like to thank the moderators for the opportunity to be a part of this panel and to present in this manner for this virtual SAGES meeting. So hope everyone is well, and thank you.